Great, thank you. Hi, everybody. I'm Anna McGowan. I am a Gundungurra woman with Wiradjuri descent, and I'm the Aboriginal Workforce Consultant for Sydney Local Health District. Before I start my presentation, I would also like to acknowledge the country that I'm working and living on today, which is the Darug land. And I'd like to pay my respect to everyone that's here from all different countries and elders past and present. I would also like to acknowledge that the piece of artwork behind me was done by Leona McGrath. She's an absolutely fabulous artist. I'd also would like to acknowledge Professor Mark Harris, you know, especially with recognising Aboriginal health workers, and really resonated with his presentation. It has been so good today just to hear what others are doing, because it seems to be a new terminology when we look at Aboriginal health workers. So if we can just progress to Aboriginal Workforce Consultants role, that'd be great. Okay, so what is the Aboriginal Workforce Consultant? You know, this position covers many things in Aboriginal workforce. We provide support in the development of positions, and it's not just general positions and not just getting Aboriginal people in general positions, it's also identified positions. It's supporting, you know, if Aboriginal health worker, if the Aboriginal health unit is developing projects, we look at what would be the most suitable positions that would be able to carry this project successfully. Meeting workplace targets from the Ministry of Health. We have our target at the moment is 3% across all salary bands and 3% headcount, but this will be going up next year to 4%. And an employee and workplace cultural competence. And in this, it's about recruitment, looking at talent pools. How do we attract Aboriginal people coming into the district? And one of the most important things is their retention rate. You know, if we have a large cohort of Aboriginal people who are not happy in their positions, there's a good chance that my mob's not going to hang around. The next slide is on the current data. So far, and I would really like just to remind that everyone here is that we have over 13,000 other staff in Sydney Local Health District. So when you look at the data for Aboriginal health workers, this is exclusively for Aboriginal health workers and positions that sit into that. We have 15 Aboriginal health workers out of 182 Aboriginal people employed in Sydney Local. You know, 8.24% is not a high percentage for us because we have such a large population. Even though it can be transient at times, it is one of the most popular health districts to come into health services for my mob. So the breakup for the positions, as you can see, there are 2 senior Aboriginal health workers, a principal. We actually have 4 ALOs, but 2 positions are vacant. And we have 10 Aboriginal health workers. In recruitment, we do have quite a few identified positions, but at the moment we have 1 cancer care coordinator position of palliative care, 4 Aboriginal health workers and 2 Aboriginal health practitioners. I mentioned the RPA emergency Aboriginal project because this is a new project. It's a pilot project, and we have got some really good people involved in the working group. And what it is aiming at, we have a high level of Aboriginal people self-discharging before they have any type of clinical intervention. And we're hoping that having 2 Aboriginal health workers and 2 Aboriginal health practitioners, that on a 7-day roster, that we will be able to support Aboriginal people coming into emergency and encourage and listen to their stories and provide the support, I guess, and the knowledge, you know, the cultural knowledge that we bring to this position, that we may be able to encourage Aboriginal people to first trust the service that you're in, to listen and to hear what people are saying, and help with the medical literacy that I know when I first came into health, I had no idea. I would just nod yes, or if I got scared, I would walk, you know, and a lot of Aboriginal people are very similar to my reaction. So, Aboriginal workforce, community navigator roles. As you can see that I've identified up here, you know, this category includes roles of Aboriginal community health workers, Aboriginal hospital liaison and community liaison officer positions. These roles are non-clinical and provide a variety of services in community and or our hospital settings. These services include advocacy, support, liaison, and health promotion. Principal Aboriginal health worker. Have I missed it? So the next one is health practitioner. Okay, thank you. Aboriginal health practitioner. These roles now, we are getting a lot more support from the ministry that it is recommended that all health districts have at least over 2 Aboriginal health practitioners. Now, I'm not sure if people, and I'm sure that there are some here that are familiar with this position, but AHPs can really fill the gap when it comes to Aboriginal people coming into services. They may not necessarily want to see a nurse. They may not necessarily want to be triaged by others, but Aboriginal health practitioners can triage. They can do they will be trained in the core competencies with clinical intervention. And it's really important. I find that these positions are not just about being the Aboriginal health worker who will be able to liaise and have the conversation. They can also provide and be part of your journey through the system. And they also, working in emergency or any other clinical settings, if there is no Aboriginal clients, they're also able to help you triaging with other clients that are coming in. It's an incredible position. And I really we're looking at having 4 before the end of the year, which is exciting for us. Principal Aboriginal health worker. It's fairly new positions, and we do have a principal Aboriginal health worker in women's health, working around DV education. Principal Aboriginal health workers will provide, implement and review Aboriginal primary healthcare strategy and policies, and may be responsible for the supervision and training of Aboriginal health workers. These positions are the only position under the Aboriginal Health Workers Award that you will be identified for having a degree. Senior Aboriginal health workers. Senior Aboriginal health workers work alongside community in the development of programs to raise awareness of health concerns and to reduce risk. These positions are paramount to changes in health for Aboriginal communities. They work really closely to identifying and mapping out the emerging needs that are coming out of the community. They build up strong relationships from the young to the age. It is we have 2 senior Aboriginal health workers, male and female. It gets really tricky when we think that one person can deal with male, or not deal with, but work with men and women from community, because we have some really strong traditional culture in Eora Nation, and it's not appropriate at times. Sometimes there's generic information that either person can educate in community, but then sometimes we need a male and a female worker. So I'm really aware that I've got like 5 minutes, so my apologies if I'm just kind of going through this, but please know that we're going to have a discussion later, and I'm only so happy to break this down for you and to discuss further about this. Some of the challenges that Aboriginal health workers have is that really are affected by high rates of stress, burnout, staff turnover, which can impact primary healthcare delivery to Aboriginal people, not understanding the importance of the role of Aboriginal health workers. Some have said that they become invisible when they don't feel like they're part of the team, that they're just an add-on, which shows them very little respect. Non-Aboriginal staff being able to demonstrate culturally safe and sensitive practices when working alongside Aboriginal staff members and their clients. Not recognising that Aboriginal health workers confidently walk as both an Aboriginal person and a health professional. Aboriginal health workers often face challenges as a consequence of stereotypes and lack of recognition for their abilities. Limited consideration given to, excuse me, Aboriginal health workers' depth of cultural knowledge. Sorry, I'll just have a bit of a drink here. Discrimination and exclusion of being involved in team consultations or discussions. There is a high expectations of Aboriginal health workers, and this is inclusive of, you know, the cultural. We have an incredible cultural team that sits within RPA Virtual, and they are then becoming the cultural broker of this district. But there are such, in other positions, there's such a high level of expectations with little understanding from the system of what these roles do. And it's also, I guess, one of the things that I find working, you know, as a workforce consultant is that the salary band is not equitable at all. I've got absolutely brilliant Aboriginal health workers, or I should say we do as Sydney Local, and it covers from senior to, you know, health practitioners to Aboriginal health workers, and they are under a salary band that does not recognise anyone's degree. We are currently at the moment with the ministry looking at revising because it changed in 2016. So some of the achievements that we have, I was just looking at, you know, because I didn't have a long time to, this has been a very rough job, so my apologies for this. But it really is paramount. Aboriginal health workers are really paramount. If we are serious about looking at closing the gap, and if this district is serious about Aboriginal health being the best nationally, we need to do something in regards to building a really strong, resilient Aboriginal workforce. And some of the wonderful achievements that our Aboriginal workforce does is that, you know, providing public protection with enhanced safety and quality in the delivery of clinical services for Aboriginal people, increase the access of care for all services, providing flexible, holistic and culturally sensitive health services to Aboriginal clients and the community to achieve better health outcomes and better access to health services for Aboriginal people. Ensuring the provision of Aboriginal primary health care is culturally and clinically equitable. Identifying cultural security and safety is embedded in all services. Education for patients and community on disease prevention and health promotion. Having local community knowledge, ensuring a holistic approach to healthcare is undertaken, and also they're the cultural brokers and they're the translator with the health literacy. Now, when I was writing this, you know, one of the things that came out for me is that we're all in this together. You know, it is, we can talk about, you know, Aboriginal health workers, and we all know that they've been the navigators since prior to 1972, you know, Aboriginal people have been working in communities for a long time, long before these positions ever were developed. Now that these positions are coming up, is that we have a really great health district, and this is a chance that we can absolutely work together, because it's not going to work. It is not going to work if we're not able to work together and build an Aboriginal workforce that delivers health care to Aboriginal people by absolutely accepting and really valuing the people who are in these positions. So, and I just want to end with this, and, you know, I went right through a timeline for Aboriginal health, but I looked at the 6 minutes, and I'm not sure how long I've been going for. But I looked at, God, you know, how long have we had people working in community that did not work in any health district, that worked on their own long before the AMSs were developed, long before that there was any groups or ARP or anything like this. And I thought, well, you know, obviously it's going for a long time because our health was absolutely impeccable many, 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 many years ago. And one thing that came out of me was that, or I resonated with, was that we were not, we only became human 2 years after the Beatles joined. So that's kind of, you know, well, it's in my age group, but that puts the reality on it, is that we can do better. We have the great people and we can do better. I've been asked who the artist is. It's Leona McGrath. She works for Cancer Australia, used to work at the Ministry in Nursing. Absolutely brilliant woman. Time's up. Thank you very much.
So hello everyone, and thank you very much for inviting me here today. It's an absolute pleasure to be here, and I just wanted to say Thank you to everyone who's, just presented. It's been really insightful. So, as Ben mentioned, I'm the Director of the Diversity Programs and Strategy Hub for Sydney Local Health District, and which sits under Population Health. And I'll be talking to you today about one of the models that Sydney Local Health District has adopted to work with migrant communities. So next slide, please. Thank you very much. So the Cultural Support Program was established in 2018 as a partnership between Sydney Local Health District, South East Sydney Local Health District, and the Central and Eastern Sydney PHN, so that they're the funding partners. And really it was established to meet the increasing demand on health services driven by an increase in migration. So the Cultural Support Program consists of a pool of bilingual, bicultural staff whose task it is to work across or to work with services to improve access to and the delivery of programs for culturally and linguistically diverse communities. The role of the program is to integrate with a range of clinical and non-clinical services, such as, say, maternal and child services, cancer services, diabetes, Asian chronic care, etc., to add value by providing a cultural and linguistic dimension to their programs and services. The program does not run any programs or services of its own. So that's a really important thing to recognise. The cultural support workers come from a very broad range of professional backgrounds, but they are selected according to a very stringent set of selection criteria, which include things such as not just the ability to speak, read and write in one or more languages, but also experience in working in community health or health promotion or within broader health contexts, as well as a good understanding and knowledge of their community health networks. So these are the sorts of foundational skills and experiences that are required in order to become a cultural support worker. Now, it's important to note that the cultural support program is quite unique, but it is also a very long-standing, it's based on a very long-standing model, which has in fact been in place in Sydney Local Health District since 1992 and has been part of the multicultural HIV and hepatitis service that I also manage. So it's a model that has really been road tested over 30 years and has been refined and adapted to respond to the current challenges. Next slide, please. Thank you. So this slide just gives you a bit of an idea of the current language and community groups that are covered by the Cultural Support Program. As you can see, there is a mix of established as well as new and emerging communities. Now, recruitment to these languages is evidence-based. So it's based on things such as local demographics, hospital data, migration statistics, and broader population-based data that we draw on quite regularly to ensure that we actually have the right mix of languages and cultures represented within that pool to be able to respond to the needs of the communities. The recruitment to the Cultural Support Program generally occurs every 2 years, and that's really due to attrition, but also to ensure that we do maintain responsiveness in light of, in recognition of the fact that migration is incredibly dynamic and patterns shift quite regularly. Thank you. Next slide, please. Okay, so this so the Cultural Support Program and cultural support workers actually have quite a broad scope of practice. So the sorts of things that cultural support workers do include community engagement, community education, resource development, research, media and communications, and health system navigation. Now, cultural support workers, when they enter the program, receive a 2.5-day induction training to essentially induct them to their role. However, there is also an annual program of both skills-based and content-based training. So looking at things such as, in-language development or how to participate in research, as well as content-based, so looking at how to deliver, for example, bowel screening or breast screening education. So those sorts of things. And cultural support workers need to attain those skills throughout the year in order to remain functional within the program. In addition, the cultural support workers also undertake regular support and supervision from the cultural support program coordinator, and that includes briefings, debriefings, and regular staff meetings. Next slide, please. So I thought I'd give you a little example of sort of a bit of a wraparound example of the program, and I chose, of course, something that is still unfortunately quite topical, which is the COVID response. So really the significance of the cultural support program became very clear during the pandemic, where the focus obviously was on preventing hospital admissions and keeping the community safe. So the flexibility and responsiveness of the model were exactly what was needed to implement the COVID response. And the cultural support program was in fact part of that the district's response in COVID right from the beginning, where our cultural support workers were required to undertake welfare checks for travellers returning to Australia from mainland China initially, and also engaging in community liaison with Chinese community organisations to ensure that people were safe. That went on to that transition to providing in-language concierge and cultural liaison at pop-up testing and vaccination clinics in areas of high migrant density, as well as engaging in contact tracing in language on behalf of the public health unit and conducting audits of commercial strips to ensure that the right resources in the right languages were available. Next slide, please. We also worked very closely with our comms team to develop a broad range of multilingual resources in 20 priority languages. And we developed multi-platform communication campaigns targeting priority communities in response to local clusters, cases and hotspots. And finally, we conducted a range of focus groups in language with community members to really understand the barriers and enablers to vaccination uptake. And we did that with both new and emerging communities as well as some of the more established communities to really sort of get a picture of the program. Now I've been asked, could we go to the next slide, please? Been asked to sort of consider what the benefits and challenges are. And I think it's quite clear to see that the benefit of this particular model is that it is very responsive. It has an agility and a flexibility that enables it to adapt to emerging challenges. But also the way that the program is structured is it's got room to grow. In other words, there are opportunities to continue to broaden the scope of practice of the cultural support workers through appropriate training and education. And finally, I think one of the benefits is actually a benefit to the participants or to our cultural support workers, because it does provide an opportunity for entry-level work into the health system. And we're really, really proud of that. And over the years, some of our cultural support workers have gone on to become, permanent members of staffing at various health services across a number of different services. So that's something that we're really, really proud of. Of course, some of the challenges continue to be for us the recruitment. And so there is a level of attrition, as can be, as is normal, and particularly when there is the disturbance to migrant flows that we've seen during the pandemic. It does have a flow-on effect onto our recruitment, and so that becomes a bit of a challenge. Availability of cultural support workers is not always there. And also there might be some confusion around role delineation between the cultural support workers and the interpreters. And I've been asked to wrap up, so thank you very much.
I'd like to start by acknowledging the traditional owners of the land that we're all meeting on today, the Bidjigal people, and pay my respects to elders past, present and emerging. Next slide. So the priority populations and places that I focus on mostly align with suburbs in our district where there are high concentrations of social housing. So this map here just indicates where they are. It's a map borrowed from DCJ. And I've just listed a few of those suburbs, but also our partners who we work with because they're incredibly important. Today I'm going to be focusing on a program we're delivering in Waterloo. Next slide. So Waterloo has a population that's very diverse, and 28% of the population live in social housing. As we know, people who live in social housing are often vulnerable. They often have lots of medical conditions, which are exacerbated by the barriers they experience to receiving care and also social factors. A couple of years ago, some residents approached the district with concerns about street drinking, mental health needs of some community members and drug and alcohol needs of community members. So the district held 2 community forums to try and come up with a solution and work with the community on that. And one of the outcomes of those forums was the establishment of a Healthy Living Link worker role to really bridge that gap between the residents and the health service. So that Healthy Living Link worker, is that what it's called? Yeah, is now called the Healthy Living Program Manager, and he manages the Healthy Living Program. So next slide, please. You've already met him. That's Shane Brown, who was in the video that Diana showed us before. He's our current Healthy Living Program Manager. So broadly, the aims of the program, I'm going to have to turn so I can see the slides because I haven't got my notes printed. The aims of the program are really to work with the community on an ongoing way to identify what the needs are over time, provide that navigation that we all know about, that we're here to talk about, but also to advocate as to be an advocate or a broker to services, and also to advocate for what might need to change with health and social services to meet the needs of the community at that point in time. The worker supports community development and again provides that link between the health service, NGOs and the community. It's supported by a program advisory group which is comprised of community members, NGO staff and district staff. And it's graded as a health service manager role, which I think is really important because this role does 50% face-to-face work, navigation work, but it also is responsible for a whole host of community-based projects. Leadership is through integration and partnerships, and the role's not aligned to any one clinical stream or any one facility. So clinical services integration and population health is a district-wide or executive unit, and this role isn't aligned to any of the services, so it doesn't need to report through those services. Okay, next slide. So like I said before, the role has 3 main functions. There's the navigation component, project work, and also workforce support. And those 3 activities really influence each other. So obviously working, the navigation work that's done is a real ear on the ground about what's going on in the community, which then informs the project work. The project work is of course done with the community, which can then inform the way the navigation work occurs. And also that supports the work that this worker is doing in terms of supporting and coaching the NGO workforce and also the supervision arrangements that he has with some of the district staff. Referrals for the navigation work, thank you, come through directly from community, but also through some of the community organisations and community welfare and other government services. So really that's a nice diagram that sort of conveys the pathway and then, you know, acting as that broker onto our health services, but then making sure those health services and what's going on with those services connects back to the referring agencies and back to community. Next slide, please. So this is just some activity that the current worker has reported for the last financial year. Got to remember that COVID was a huge activity and he was redeployed to some pandemic activities. However, his role was so crucial and so helpful in our outbreak response with our more vulnerable populations. So over the past financial year, he's supported 58 people who've had, on average, 5 one-hour meetings, plus admin work. Of course, there's the phone calls and there's the liaising with other agencies that's on top of that work as well. He also provides a lot of once-off support to community members that's not included in that 58 count, and we will be collecting that data soon because that's another bulk of his work. He's provided 130 instances of navigation advice to staff from NGOs and staff from the district as well, just to support them on how to navigate the health and social care system for Waterloo residents. Can we just go back? Yeah. So those are some of the priority health issues that people are coming to him with. They might come and say, I need help with this, or he might uncover that after developing a bit of a rapport with them. He's also done 7 projects over that time, and like I said before, spent a significant amount of time on COVID redeployment. And some of the challenges that he's expressed over that period of time have mostly been around the availability and access to services. So they're challenges that the community experience, he's experiencing them too. And one example is around hoarding and squalor, and finding services to support the needs of people who are experiencing hoarding and squalor. So it's really challenging to work with a person, find out what their needs are, and then not be able to refer them on to a service in a prompt way. Okay, next slide. So the role was evaluated a few years post-implementation. I forgot to include the reference, which is shocking, but there's a really good paper published, one of the authors is here, and you contact me and I can get it to you. But this is a component of the evaluation that was done where participants from the community, NGOs and the health district were interviewed based on or asking them about what their perceptions of the impact of the role were. And I guess in a positive way, their perceptions of the impact of the role really aligned with the aims of the role, which is fantastic. The success factors, so why were we achieving the aims? They've said that the work has got that trusted and respected presence in the community. He's got fantastic communication and interpersonal skills, and he's got a great knowledge of the community. And I guess one important thing to know about this worker, he's actually worked in the community for 30 years or over 30 years. And I guess, Alex, that's something you talked about, is that importance about recruiting people who are familiar with the community. For me, it's something to think about if, God forbid he ever leaves, how would we replace this person who's got that long history with the community, and how can we identify someone who's got similar skills? And the constraints of the role, I guess we've talked about before, and they align with what he mentioned. So it's that difficulty finding services, but also the difficulty influencing health system change as just one single person. Okay, next slide. So our next steps, so the first 5 listed here are the recommendations from our evaluation. And I'm happy to say that in the years since the evaluation was done, we are well on our way to implementing all of these recommendations. And I will just focus on, I'm running out of time, but the last point there, I think we really need to consider what this worker is doing and how we can replicate the success of this role in other communities, but of course making sure we're localising it to the community's needs. And how can we maximise this excellent the Healthy Living Program Manager to be in a leadership role amongst health navigators, but keeping in mind that he might not necessarily be aligned with the other communities that he's working with or have that history with them, but how can we pull from his skills and experience to build a workforce? That's about it. Thank you.
Thanks for having me here today. I'm speaking about the Extend programme, which was the result of, next slide please. It was a long 2015. Julie Finch is the programme manager for chronic care and complex care. There was a post-hospital discharge and readmission rates were 30% within 28 days. Within the cardiac chronic care. It basically impacted on the wait list, and it meant people weren't being seen and followed up as quickly as possible and for improved health outcomes. The aim was to improve well-being, compliance with medication, exercise plans, healthy eating, increase follow-ups, integrate acute, community and primary care for optimal discharge, sort of create a specialist sub-acute care within 5 days of discharge from hospital, and train and utilise AINs to extend the reach of the cardiac team as close as possible to discharge, and to support the client to manage their health post-discharge. So it was always an enablement model rather than doing for. We're teaching the client to do for themselves and show them how to do, to allow them to take and show what's available and help with those links. Next slide, please. So the aims: unplanned and avoidable hospitals, we're reducing complications of chronic diseases and progressions of chronic diseases, and duplication of services and unnecessary interventions, which is often the result of readmitting and non-follow-up or delay in follow-up. And increasing access to primary health care, education and coaching, support for vulnerable clients, care navigation for clients and families, and improve integration of care between health professionals, all teams, NGOs and community and care providers and home care package providers. Quality of life increase for people with chronic disease, and improving the relationship between psychosocial issues impacting on health and well-being, and taking that into mind, and the health system's capacity to respond to the needs of people with complex needs. Okay, next slide, please. The outcome of this follow-up was reduced admissions by 10% in 12 months, medication reconciliation, and link to follow-up appointments in GPs. So it meant that we discovered that people were not taking the medications as expected. For instance, they would go home with their discharge medications and come home and take the ones their GP had previously given them. In some cases, they were doubling up. Sometimes they were seeing 2 GPs, getting 2 sets of medications. So it was a really important thing, as we know, in terms of immediate safety. The language impacted on readmission rates, and that's something that we're looking into, which I'll talk about later. There's decreased waiting times for cardiac chronic care services as a result of this intervention. It also meant that the outreach worker could escalate people and almost act as a sort of triage for the service, so those who were seen as more urgent were seen more quickly. Education model was developed, and then in 2018 a grant application for extension to include more care, because it was noted that there was a multitude of factors, including age, multiple conditions, socioeconomics and cultural issues that may have impacted, and these were the areas that were planned for target. Next slide, please. So the aims were to include follow-up within 48 hours of discharge, to reinforce the discharge plan, to develop patient self-management strategies, and engagement with the GP in a timely manner, and the GP to be aware of the discharge plan. Very often, the GP listed on the medical records is actually one from years ago, and this letter of care goes out into space, and there's no follow-up. So that's really quite an important factor. And encouraging the GP to be central pivot point of the patient, primary health care, and to reduce the readmission rate. Next slide, please. These were client comments. I've got quite a few client-based aspects in here. These were comments before follow-up. I cried for a few days. As long as I can manage this fluid thing, don't talk about the medications, I've just got so many. It's scary on my own. I can't work it out. He's slightly more depressed and doesn't eat anymore. We're searching what we're going to do next. I don't know what the hospital's going to do. All these things, scared, I don't know what I'm taking them for. I read the referrals, but I don't understand them. I think this is where it's really important to put personal experiences in with our knowledge and understanding of other people's experiences. We've all gone to systems and information sessions and doctors where we've come away thinking, I can't remember what it was they said. Or, what does it say? I can't remember. And what you understand in a particular time in a hospital setting and you go home may well be lost. So they talk about having information shared with individuals across a range of subjects, and what is taken in, and it may take several times for someone to repeat it before it's taken in, and they may feel like it's the first time they've heard it. Okay, next slide, please. So, review of the extend in 2019, we found that a percentage of patients with identified issues was over 40%. Most of them were medication and other. We also included carer stress, transport, shopping, personal care, mobility, and meals. On this, we haven't identified things such as psychosocial, family dynamics, finances. There are a whole scope of other psychosocial which will impact into this as well, which is something to look for in future. The days to see the GP, we got about close to 80% seeing the GP within 5 days, which is a really great outcome. Next slide, please. This is what the clients felt. So the first visit is purple. So their health, they felt, was closer to good to poor. And then after the final visit, there's a definite shift towards the latter half, slightly improved health. The quality of life, we'll notice that's actually significantly different towards the final visit. So it actually impacts on the client's reports. Next slide, please. This is the client we tend to find. They often wait till they're desperate to get help. They find it difficult to ask for help. They feel better immediately after they have had intervention, so they don't feel the need for follow-up. They think they're going to be fine. There's a pride element too. They don't know how to access services. They don't know what services are available. There's not any cultural services that are appropriate. There can be cultural limitations to asking for help or presenting with difficulties. There's stress, cognition, insight, which limits management at home. And the home environment and relationships may impact the family and recovery in the function. Next slide, please. So the importance of early follow-up is medication, remembering the information, as I said, not sure how to manage or understand the condition, so education and warning signs and coaching for managing. Not sure when to have to be reviewed or by whom. In hospital, they had someone to ask, someone to remind them, someone to prompt them. And they were often assessed on that ability of a flat service, a small amount to walk, with people prompting, reminding, well lit, and that was their assessment to say they were safe to go home. When they get to the home, we actually get to actually see the situation where there's steps, uneven carpet, poor lighting, and fatigue, and all those other aspects. Overwhelmed and motivational barriers. So it's it helps improve continuity of care, and predictions of how they manage are based on the hospital assessment. Next slide, please. So we look at the whole person as much as possible, especially building rapport and identifying risks to our workers as well. So it's quite important to make sure we support them through that. Also doing some pre-admission assessments about their knowledge and what we hope to achieve. Looking at the whole person and also reinforcing the discharge summary. And intervention is client-based. Next slide, please. So health coaching, assistance to complex issues, specialist linkage, all the possibilities, as well as referring and escalating within the team. Okay, next slide. In the health setting, we've got access to notes. We can increase information about the client and what's needed for health and well-being. Documentation can be communicated for ongoing medical teams. Identifications of concerns and links can be followed up with where's needed in the health team, and support within the team from the nurses who are working in that client group. It's a structure that ensures growth and development and access to learning and resources. Medical case conferences, and also links to the community in previous services, and establish outcome measures. Safety huddles, peer support, debriefing in situations where we go into a client home where it's a privilege, but also there are a great many factors. I think we're just about finished there. Next slide. Intervention, patient not taking medication, patient didn't have glasses, and getting to optometrist, difference in the patient dosage. Next slide. More scenarios. Heart failure in patient at 1.2 litres of fluid restriction, but had to be given 3 litres preparation for colonoscopy. So working out information and sharing that information. Next slide. Next steps. Well, we're linking with the University of New South Wales to research the impact of community health navigators on client wellbeing. We've got 3 community health navigators now employed, and we're starting the process in November of actually getting clients for the research program based on the Extend model. Thank you.
So before I start, I'd just like to start by acknowledging the traditional owners of the land that I'm on today, which is the Wongal people. They always have owned the land, and sovereignty was never ceded. The last time I spent some time at a presentation with Aboriginal folk, they talked a little bit about taking time when you do these acknowledgements to learn a little bit about the land that you're on and say something more interesting. So I just did a little bit of research to say, and Anna, don't make fun of me if it sounds dumb, Warrami, which is hello, from the Wongal people of the Inner West. And I found out that the Inner West, which is my main tribe of people that I feel connected to in community, were connected by language to the Darug tribe, which is where I originally come, which Blacktown. So I thought that's a bit of learning from today. And yeah, so I just thought I wanted to do a more of a meaningful acknowledgement if I can. I also like to acknowledge those of us today with lived experience of mental distress, extreme states, suicidal thoughts, and bereavement. Why I chose this picture, choice not force. This is Judy Chamberlain. She's an American activist from the 60s. She became an activist after she was involuntarily admitted to an asylum in America. And when she finally got out, she wrote a book that's one of the seminal texts of the movement called On Our Own, Patient-Controlled Alternatives to the Mental Health System. And I think her message, choice not force, is still relevant today to the work that we do. So I've got kind of a funny presentation. It's not as serious as everyone else's, but it is serious work. So how I became a peer, I worked as a mental health support worker, and I grew up as a child of a person with a mental illness and an alcoholic, and I myself lived with mental health concerns since I was a teenager, and then went on to deal with issues around substance misuse and homelessness. When I worked as a mental health support worker, I was often termed as a threat, saying mentally ill people shouldn't work with mentally ill people. I always wish I could be open about my experience instead of trying to fly under the radar of people's perceptions and, pass for normal. And so I did a lot of things on my recovery. I studied counselling and psychotherapy. I did a lot of 12-step meetings. I still do therapy. I got a role at Sydney Local Health District as a peer worker, and I studied the Cert 4 mental health peer work. And also I went on to just study the Diploma of Leadership and Management, and now I'm in a role as a senior peer worker. So this is a little cartoon because I had this epiphany that maybe peer work was best described as Saggy Baggy Elephant. If anyone's ever read that book, where the Saggy Baggy Elephant thinks there's something wrong with him, but he hasn't found the other elephants. Hang on, someone's messaging. 4 minutes left. Okay. All right. So he said, mate, I'm really worried about these saggy bags. My skin doesn't fit like yours and it's not blue. I'm glad you've come to help. You've probably got metabolic syndrome, which leads to diabetes, cardiovascular disease, and early death. Mate, my skin's really big and it isn't blue enough. We're often evaluated through a medical frame. Have you ever thought about seeing your skin in a positive light? I've often felt ashamed about my shape too. I know it feels hard when you think you need to be blue, but you are actually a grey person. So what do peer workers do? We share experiences of being and feeling less alone. We share coping strategies. We offer practical support. We link people to services and look for places for people to reconnect to community. We insist in our teams that people use recovery-oriented language. We provide group supervision and individual supervision. So we're embedded across the multidisciplinary teams all the way from Redfern to Lakemba. We have all the same access to files and documentation as clinicians. We obviously use a strengths-based approach. We're currently opening a Safe Haven, I think next week, which is, for those of you who know Newtown's opposite the Marley Bar, where the old Ray White office was, been repurposed, so that if you feel like so terrible that you want to die, and you don't want to sit in the ED, come and sit with us, peer workers and social work, in the cafe, and we can make you a cup of tea. We've got some lovely stuff up there, like sensory things we can help you with. Okay, so I'm just thinking about the time and quickly. So we're thinking about like clinical recovery versus personal recovery. So peer workers are using their lived experience to support people to understand themselves as a person and to live a meaningful, full life with or without connections, instead of a patient thinking about recovering from their symptoms. We use the framework CHIME, connections, hope and optimism, identity, meaning and empowerment, to guide our work. Currently, coming soon, this week at Marrickville Library and Pavilion from 4 to 7, we're doing Heaps Mad, which is part of the Mad Pride movement out of the psychiatric survivor movement, reclaiming the term mad as a positive statement. We also will be featuring Jordan Raskopoulos, who was one of the funniest people ever, and she's coming to be giving us some comedy. It's an open mic, so if you're someone with lived experience or an ally, please come along, sing along with us, and join in Pride.